He spearheads the TAVR along with Dr. Moore and Dr. Carter. He did his general cardiology training, heart failure, and his interventional training from University of Cincinnati. He has multiple board certifications and publications. Despite all these qualifications, he continues to be known more for his hair and for his fast car. A lot of times he reminds me of an older brother. You know, if you have an older brother, you know how they have to do everything better than you, like every time? you always like the second player. So anyhow, I would like to invite Dr. Waheed to come on the stage. Please give him a big round of applause. For our panelists, I would like to invite Dr. Moore first. Please welcome Dr. Moore. Dr. Moore is one of our 2 cardiothoracic surgeons at the Medical Center Bowling Green. He's very accomplished and extremely well respected. I secretly wish he's on call every time I need to call a surgeon. Just because I'm not scared to call you. Next on the panel, Dr. Akbar, please. Welcome Dr. Akbar and Dr. Vashisht.
All right. Sorry, we are running short of time, I heard. And I've been tasked to get you guys out soon. I'm going to try. I don't usually drive fast. So it's an exciting time in structural heart disease. A lot is happening, and it's happening at a very fast pace. If you recall, 2 years ago, Dr. Slater was here from NYU, and he presented the TAVR revolution. At the end of the talk, I remember Dr. Moore asked him, so what do you think about this coming to small towns? And here we are. In 2 years, we have launched the program. This was launched in November last year. And we've done 27 successful transcatheter aortic valve replacements as of last Wednesday. So we've kept up the pace. So the scope of today's topic is to talk about screening TAVR patients, apply current recommendations, compare clinical outcomes in patients who are undergoing TAVR versus surgical aortic valve replacement, and for medical therapy patients in these high-risk patients, identify common complications involved with this procedure, and of course, I'm going to shed some data on how we've performed so far as compared to some clinical data that's available. Aortic stenosis, just for completeness sake, I'm going to talk about a little bit epidemiology. Aortic stenosis is the most common valvular heart disease in the older population in developing countries. About 5% of patients older than 75 years of age have aortic stenosis that's severe. And if you don't treat these patients, in 2 years, the mortality is about 50%. In 3 years, if they survive, they're only 80%, 20% of them survive it. So it's a 50% mortality in 2 years and 80% mortality in 3 years. So it's a pretty significant disease that we deal with. So what have we done so far? Since in 1960s is when the first surgical aortic valve replacement was done, and since then, surgical aortic valve replacement has been the gold standard of treating patients and improving their mortality and morbidity. Surgical aortic valve replacements especially has a very low operative mortality in patients who have not as many coexisting comorbidities. But if you recall my past slide, most of these patients are over 75 years of age. And once you hit that bracket of age, there's a lot of comorbid conditions that you deal with. And apparently, there are 1 out of every 3 patients who has aortic stenosis is so morbid medically that they don't even get referred for an aortic valve, or they are not offered surgery because of the comorbid conditions. So they are non-surgical. So for such patients, this technology has been has played a vital role. So what's transcatheter aortic valve replacement? Basically, it's more for the students and residents. It's actually a bioprosthetic valve that comes mounted on a catheter, and we take it up the femoral artery, place it into the aortic valve and then deploy it there, just like a stent. Cribier is the guy who first did it along with his colleagues in 2002, and since then, about 250,000 valves have been deployed in the United States. There are two platforms that are approved by the FDA. One of them is a balloon expandable valve that's on the right side of the screen. It's made by Edwards, it's a company. Sapien is the name of the valve. So in the future, if I say Sapien valve, it's a balloon expandable valve. And the other platform is a self-expanding valve, which is a little taller scaffold, and it has a porcine pericardium inside it, and it is self-expanding, and Medtronic makes it. It's called core valve for the future slides. So there are two platforms, and both are FDA approved now. Let's see if this will play. Technical problem. Wrong time, isn't it? So in any case, I was going to show you a video where showing the catheter going up the groin, the arch into the aorta. So basically, you deploy the valve in the native valve. So you expand the stent one way or the other, if it's a self-expanding stent or a balloon expandable stent. And then the old valve is squished behind the stent, and there's a new valve that's deployed like a parachute inside the new valve, the new stent. So that's how it's done. So in order to get good results, you need to choose your patients right, isn't it? So proper patient selection and case planning are critical for procedural success. A multidisciplinary heart team, which includes an interventional cardiologist, general cardiologist, CT surgeons, anesthesiologists, imaging specialists, nursing coordinators, and of course, a lot of staff, nursing and technical staff in the cath lab, all play a very vital role in the management of these patients. This team has to work and has to engage in a conversation with these patients, these high-risk patients and their families, to tell them about, what are the options available and what it entails and what are the complications involved with the procedure, what they can expect, and what kind of a, outcome they can look forward to. So we need to know the risks of these patients in order to have a conversation with these patients. So the patient risk must be taken into consideration while engaging with these patients in decision-making. There are 3 or 4 categories of risk in surgical risks in such patients. An operative risk is low if your perioperative mortality is less than 4%. We call it intermediate if your perioperative mortality is between 4 and 8%. This is an STS score. I'll talk more in the next slide. And your risk is high if your mortality is greater than 8%. Somewhere between 15%, we call it extreme risk. And if you're beyond 20%, usually you're inoperable, and basically it's a prohibitive risk. And we also have to be cognizant that if your patient has comorbid conditions that preclude them from having a valve, is when they have a mortality for some other cause within 12 months, then they're not candidates for valves. These are the 2 models that are available that we use around the world. One is an STS, which is the Society of Thoracic Surgeons. Predicted risk mortality, or STS-PROM for short, is what we use in the US, and there's a Euro score that our counterparts across the Atlantic use. The STS-PROM score usually tends to underestimate the mortality for some reasons I'll tell you in the next slide, and the Euro score tends to overestimate the mortality risk. No matter which score you look at, they both have some drawbacks, and because as a surgeon, the surgeon's looking for more than just the score. He's looking for extensive calcification, he or she, porcelain aorta, chest wall deformities, history of mediastinal radiation, mediastinitis, pericardial disease. Frailty is also important, we'll talk about it. Neurocognitive dysfunction and mental health issues. Frailty is especially important, and it is a measure of how much the patient can do by themselves, the ADLs. And we also look at their albumin level, see if it's less than 3.5, they are frail. If they are able to walk 5 meters or not, it's frailty. So all these are certain parameters we use to deem a patient frail. If they are frail and they don't fit the STS score, they're still high risk for surgery. So this is something important. So this is a treatment algorithm. So I'll go through it quickly. But what it generally says is that if you have a patient with aortic stenosis that is severe, with your velocities across the valve being more than 4 meters per second, or your gradient is greater than 40 millimeters, if you're symptomatic, you're going to get a valve. I'm just going to talk about general valve replacement. I'm not talking about TAVR or SAVR. They get a valve if they are symptomatic and severe. What about patients who are asymptomatic? They have severe aortic valve stenosis. They're eventually going to make it. They're going to get the valve. But if you have certain conditions like coexisting cardiomyopathy, EF less than 50%, if they're going for a bypass surgery, or if they have gradients that are really greater than 60 millimeters, they're better off getting valves sooner than later. Or if they have an abnormal treadmill test, they qualify for a valve sooner than later. What about patients who are moderate to severe aortic stenosis? If they are asymptomatic but they're going for a bypass surgery, I think they should get a valve. But if they are symptomatic and they're moderate to severe, then you decide, is there cardiomyopathy concomitant? If there is cardiomyopathy, then the gradient is low falsely because of a low flow output situation. And then you can do a dobutamine stress echo to evaluate if these symptoms are indeed coming from their tight valve or not, okay? So then if they respond to that, they get a valve. And if you can prove it, that the symptoms are coming from the valve, and then you can, they get a valve. I don't know why this is acting out. So for a transcatheter aortic valve replacement, you need to look at 4 anatomical aspects of the heart. One is the aortic valve, the aortic annulus. You've got to look at the coronary arteries and the vascular axis. In terms of investigation, of course, transthoracic echo is the cheapest, easiest, and a gold standard for assessing the physiology of the aortic valve. You want to know if it's physiologically significant, right? That's how you deem it, if it's severe aortic stenosis or not. You've got to look at the EF and see if you have any concomitant valvular disease. You need to do a chest CT. That's the best way to measure anatomy of the valve, not the physiology, because it's important for sizing the valves that we do in the cath lab. CT abdomen pelvis, of course, it's needed for us. It's a road map. So this particular picture shows the femoral axis being tortuous. So we anticipate that we may have some maneuvers to do in order to make it to the heart. So it's important to evaluate a patient for all these aspects. We look at the amount of calcium in the leaflets, so we can strategize our procedure and see if we need to do a pre-balloon angioplasty or not, and we can anticipate the more the calcium, there's more paravalvular leak that's going to be there, or perivalvular, I'm sorry. And you look at the annulus height and also the coronary height. So this coronary height is where it's the height of the coronary artery takeoff. If it's too low, then you may have a problem with putting these stents and you may occlude these arteries. So it's important information that we get. Anything above 9 millimeters is a doable case. So coronary arteries evaluation is very important. If you have a critical coronary artery stenosis, you better fix it before you do a valve, because during valve procedures, you may need to pace the patient at 180 beats per minute. Your blood pressure is going to drop for several seconds. You're going to drop that gradient across that tight coronary artery. You're going to cause an MI. You don't want to do that. So you want to evaluate the CAD, fix those arteries. Also, you want to fix them because if you end up with trouble and you have already placed a valve, it's going to be challenging, although it can be done, to get through those the openings in the valve to get to the coronary. So it's challenging, but it can be done. But you rather do it ahead so you don't have to go through this problem. Of course, the most common and default access site is the transfemoral access site, and multi-slice CT is a gold standard for that. So where are we in terms of this transcatheter aortic valve replacement in 2017? And what is the data available? There's extensive research that's done, and it's done in different cohorts of people with different risk groups. Some of the historic data is the one for these extreme risk patients who were deemed non-surgical in this partner trial. This is looking at the SAPIEN valve. Other patients who could not get a surgical valve because of their high STS score, and then they ended up getting either medical therapy or a transcatheter aortic valve replacement. And the counterpart to that was the core valve, that's a self-expanding valve, and they did their own study too, and they looked at mortality benefit. So if you got a patient who was non-surgical and got a surgical valve, their mortality was 30% less. And this was echoed in the concomitant study from the core valve. So there was a 30% decrease in morbidity and mortality. Partner 1A looked at surgical valve replacement versus transcatheter aortic valve replacement in patients at high risk. So these are folks that are STS score greater than 8. So the Partner 1A trial looked at that for SAPIEN valves, and the core valve pivotal trial looked at their own cohort of high-risk patients. And what did they see was that the SAPIEN valves, the balloon expandable valves, there was no difference between the transcatheter aortic valve replacement and the surgical aortic valve replacement in terms of survival. They both did well, both at 2 years and 5 years. So that was good data. The second counterpart was the core valve, that's a self-expanding valve, and these guys did actually a little better. The transcatheter aortic valve replacement valves did better than the surgical aortic valves in terms of mortality. And the spectrum has moved on. So this has been happening so rapidly and so fast. We went from extreme risk, inoperable patients, to high risk. So now they've done research and studies on intermediate risk. And there is data out there that says that if you do a TAVR as opposed to a SAVR on intermediate risk groups, you are probably going to have comparable mortality benefit if you're doing a SAPIEN valve. And if you're doing a core valve, you're actually, your statistically significant better outcomes with transcatheter valves as opposed to surgical valves. So intermediate risk, also patients also did better in terms of morbidity and mortality. And the other thing they looked at was this intermediate risk in Partner 2A trial, the SAPIEN trial, was that the survival was good at 12 months and 24 months, but the time to get there was very fast in terms of doing a percutaneous or a minimally invasive transcatheter aortic valve replacement as opposed to opening a chest. So this is the counterpart of the SAPIEN, that is the NOTION trial that showed that the all-cause mortality was no different if you did a transcatheter valve as opposed to a surgical valve in patients who are intermediate risk. Now these are risks between 4 and 8% STS scores. So based on all these data, now these are available for the mainstream. Anybody with intermediate risk, surgical risk, that's the European cohort. The CE is Europe. 2016, they got approved for intermediate risk patients with severe aortic valve. Both platforms have been approved. The Americans have been a little late in accepting the self-expanding valves. It just got accepted by FDA. The intermediate risk patients are now eligible for a transcatheter valve as of July 2017. So what have we learned so far? So far we have learned that TAVR has become the gold standard for those inoperable patients, right? So those guys who are sending home medically managed. Now TAVR is the gold standard for such patients. For patients at high risk, we know that TAVR is not inferior to SAVR, and more rigorous recent data have allowed intermediate risk patients also to be eligible for transcatheter aortic valve replacements. So based on these, this has been globally accepted. So we have already implanted 250,000 transcatheter aortic valves in the United States. It's expected that in the next 10 years, this is going to go by fourfolds. And what's happened to the surgical patients? What happened to the numbers in the past 4 years? The numbers has been the same. The number of folks getting surgical aortic valve has remained the same in the past 4 years, but there has been a 6-fold increase in the number of transcatheter aortic valve replacements in the population. So we project that in the future, these curves are going to dissect, and there will be more TAVRs as opposed to SAVRs in the near future. And this treatment trend is seen across the globe in the UK, in Germany, and in the US. And as time has elapsed, our surgical risk has gone from extreme to a high to intermediate risk, and that's evident on this slide, showing you that as time has gone by, your STS score has also gone down. No matter that, and then the number of balloon expandable valves to self-expanding valves are about 1/3 to 2/3 in the TVT. That's TVT is US registry, and the 40% is actually globally. So there are more balloon expandable valves than there are self-expanding valves done. So what have we learned is that, for patients who are in this higher age group and at risk, and no matter what their risk is, severe, high, or intermediate, they've done well with these valves. So as we keep implanting these devices, we are also cognizant that, they do come with certain complications, right? Every procedure entails some risk and along with the benefit. So what are the risks involved, and what kind of complications do we anticipate, foresee, and what have we seen in these patients? There are a few that I want to highlight in my talk today. Some of them are some complications like stroke, conduction problems, paravalvular leaks, and vascular trauma. So this is basically just looking at all the cohorts, all the studies, the extreme risk to the high risk, the intermediate risk. The orange is the self-expanding stents, and these are the balloon expandable stents. So no matter how you look at it, if you look at the weighted averages, the stroke rate is about 4.2%. And the permanent pacemaker placement, now you have to remember that you're putting a metal ring and you're going to expand it across the aortic valve, so there is the conduction system sitting right behind it. So there are a group of patients that are going to not like this, and they're going to have some conduction problems. They may end up needing pacemakers. That happens both with surgical and with transcatheter aortic valves. So we see about 10% or 11% of these patients ending up with a new pacemaker. Vascular complications have been 7.7% average across the board. And paravalvular leaks, now I'm going to categorize that as moderate to severe leaks are the more significant ones. And there are about 10% of that, no matter which study you look at, the average is about 10%. Now, based on these complications, the industries are trying to compete with each other, right? Everybody wants to do better. We want to do better for the patients. We want to minimize these complications, got to have a better outcome. So the company is working really hard in making better and better devices. And we have better devices as time's gone by. The self-expanding stent now we have is actually they have an extended skirt around it at the bottom that keeps the paravalvular leak at a minimum. And there is one valve called the Lotus that the Boston Scientific is making rather as is in the market, which actually has obliterated this basically from the technology they've created. So it's still growing, although we've come a far way, but technology continues to grow. So that was the studies, and that's what we saw was the complication rate. But in the real world, what do we see? Do we see a comparable complication rate? There is this analysis of this data that's available from a pool of literature that's come back and from experiences from across the globe. And this is actually looking at that experience. And there are about 6,000 Sapien valves and 5,000 Evolute valves. The Lotus and the other valves are not yet freely available in the market for right now. But they have found that your stroke rates have been about the same, about 3%. There were 4% in the studies. It's actually lower now because of the newer devices. So it's actually gone down. And also your stroke rate was less. That's the slide. And this is the one that's showing you the pacemaker implantation rate has also gone down since the newer technology has kicked in. And this is the paravalvular leak. I was telling you that this is the new valve that is showing a great, making a lot of noise in terms of obliterating the paravalvular leak in these patients. So that's also better than what the studies have showed. So major vascular complications have gone down also. It's under 5% as opposed to close to 10%. The reason, again, is that we have used better platforms, smaller catheters, and more conformable catheters for our procedure. So how have we done? We've launched this, our TAVR program in November of last year. We've done 27 cases. I'm going to compare our data to a similar high-risk. We've done all high-risk patients. We have not done intermediate as many thus far, because the intermediate for the core valve just got approved by FDA in July. That was a month ago or a couple months ago. So I'm going to compare that with an Evolute R valve for extreme and high-risk patients. So here's the data. Basically, we've done about 22 patients. On the 27, I had to exclude the patients for the 30-day, so I can include the 30-day mortality and 30-day pacemaker. That's what the study looked at. So there are 5 patients that we have done since this period. So the normal, the demographics basically matched as much. We had more peripheral vascular disease patients, and we had no patients with a permanent pacemaker as opposed to 10% who had an old pacemaker. And we've used general anesthesia in all our patients. We've used femoral access in all our patients. We have pre-dilated the valve because there was calcium in the valve leaflets in only 18% as opposed to 96%. And post-dilated about similar, 22% of patients. And what about the endpoints? Absence of mortality. We have had no mortality in the 30-day period for that cohort of groups. Procedural mortality, it's not a 30-day mortality. So on the table mortality, we had 0, thank God, similar to the group. And we had accurate positioning of the valve. We had no problems with that. Absence of moderate to severe AI in about 95% of the cases. And we had a mean gradient less than 20%, about 95% of the cases. So we've done, if not equal, a little bit better than our, the study itself. And our all-cause mortality is a 30-day mortality. We had 1 and death, and then our strokes was 0, vascular complications was 0, and the permanent pacemaker placement was less than the study itself at 4.5%. What about the physiology and the anatomy? The valve area pre was 0.78 and post-valve area was 2.2 as opposed to 0.6 and 1.9. Our gradient across the valve went from 43 as an average to a 7.7, also did better than the study itself. So what we learned is that, the new devices we've incorporated, we have cut down the complication rate. So what do we have now? So we've done well, and we're doing good. We are happy with the progress we've made. So are we satisfied here, or are we going to look for something more? Because that's what interventional cardiology is, and I'm sure any group of cardiology, any faculty in cardiology is looking for that. What's next? And it's exciting for interventional cardiology because there's something that's coming in the future. And what's coming in the future, of course, we're going to try to venture and grow our tentacles into the lower risk groups. There is ongoing trials now with the self-expanding trial in the US. It's called the Medtronic makes it. And then there is the SAPIEN valve also in the US and Canada. We have a UK counterpart of the trial looking at low-risk patients. And then, of course, the Nordic Notion 2 looking at low-risk patients. Times evolve, we've got an Evolute Pro. Evolute Pro is the latest device in the self-expanding, which has this pericardial tissue wrap at the bottom of the ring that helps prevent the paravalvular leak. The Sapiens made their valves more malleable and more deployable with lesser French sizes. And of course, the Lotus Edge is this Boston Scientific valve that's coming in the market that is going to obliterate the paravalvular leaks. 2 cohorts of patients that are important are the patients who have moderate to severe AS, but they have cardiomyopathy, symptoms of heart failure. So are they ready for a surgery or not? There is a study ongoing. It's called the TAVR Unload that's looking at this population to see if we can put in a TAVR sooner so we can decrease their mortality and morbidity. And there's another cohort of patients they're looking at is early TAVR, is patients with severe AS that are asymptomatic. Right as of now, we don't treat them unless their gradient is very high. But there is a group of, there's a study ongoing that's looking at these asymptomatic patients, putting them on medical therapy versus doing TAVR. There's a couple groups of patients that we need to be worried about. Is the bicuspid aortic valve group. We don't usually include them in TAVRs, and none of these studies have included it just for more anatomical reasons, because the valve is more like a fish mouth kind of a situation where you cannot put in a cylindrical valve like the SAPIEN valve and expand it, or a self-expanding valve, because you're going to end up with a lot of paravalvular leak and you're going to cause trouble. Paravalvular leaks are really important, are a problematic thing, okay? If you have cardiomyopathy and you have paravalvular leak, your patients are not going to do well. So you've got to be really cognizant on how you strategize and what you look for as complications in these patients. So it's a big deal having paravalvular leaks, moderate to severe. The outcomes are not going to be good. So that's why the bicuspid aortic valves have not been as easily accepted in the TAVR world. Another group of patients are these guys who have had bioprosthetic valves. Bioprosthetic valves usually last 10 to an average of 15 years. So what happens after 15 years? The standard of care now is you go back, do another redo on these patients. By now, they were probably 65 or whatever when you gave a bioprosthetic valve. They're 75. They have a hostile mediastinum. You already opened them up once. So it's a high-risk population that you deal with. We've always done surgeries on these patients until the TAVR came into force. So FDA has approved this for patients with a valve. So valve and valves is approved, where actually you put the valve through the previous surgical valve and deploy it just like in a native valve. Of these, the SAPIENs and the self-expanding does a little better in such situation because the self-expanding valve sits above the native valve. So you're not actually having a valve in front of a valve, so your effective orifice is not compromised. But as opposed to in SAPIEN, the balloon expandable valve, the new valve is right inside or right along the old valve. So your effective orifice is just the sum of these two. So it's going to get narrower. So your velocities and your gradients are going to be higher. So the evolute valve does much better in valve and valve situations. So that's something, a cohort of patients that we come across, and this is a therapy to offer them with less morbidity and mortality. So final thoughts, TAVR is now proven in patients at intermediate risks, which represents the combination of rigorous clinical trials that have gone through. There is significant clinical investment in newer technology for younger patients at lower risks, and it's possible that TAVR will be an alternative therapy to patients with moderate aortic stenosis with cardiomyopathy, or for asymptomatic patients with severe aortic stenosis. It's a matter of time, hopefully, and we'll be able to help these guys out because you want to catch them sooner than later. And overall, the transcatheter valve therapy is incredibly bright, the future. It's expected that in the next 10 years, we'll be implanting about 300,000 valves at least. So that's the state of the affairs. That's our hot team. Myself from the group and Jerry Roy. We are two interventional cardiologists, of course. Dr. Carter, Dr. Moore are the cardiothoracic surgeons. We have an anesthesia team. We have the valve coordinator, Rene Coombs, keeps us all sane. Radiologists, cath lab technicians, cath lab nurses, OR team, echo techs, valve representatives. We all are a team. Thanks a lot. Hopefully, I didn't go too long and it was worth your time.
Thank you, Dr. Wahid, for that excellent, very comprehensive presentation. To think that in a couple of years, starting as a fellow at UM, they were part of the Partner 1A trial and all that progress that has been made in the last 7 years. So I know it's approved for high-risk patients, STS score greater than 8, intermediate risk 4 to 8, and now you're looking at low risk. Is the medical center going to be part of that study?
Actually, we are not part of that study, but the study is ongoing. They've already, there are 62 centers, 62 for the core valve and about 68 for the SAPIEN valve. No, we are not enrolling any of those. Right now, we are actually trying to get our feet wet on the intermediate risk.
Okay. Thank you.
Thank you.
Just a couple of comments. I think that was an outstanding review of both the literature, where we are in TAVR, and what we're doing at the medical center. I think this population, the prohibitive risk population, has frustrated all of us throughout the years, because when somebody has aortic stenosis and you can't replace their valve, we're just waiting for them to die. And so this is a huge advance in medical therapy for these patients. We were very fortunate at the medical center that we were one of the few community hospitals that had that met the criteria to be able to do these. And now we're looking at intermediate risks. The one thing I'd like Dr. Waheed to comment on, and what we're looking at into the future, is durability on this valve. I mean, what do you think that is going to be? And you know, if we're going to offer it to low-risk patients who have long survival, durability is going to be the big question.
Yeah, I agree, Dr. Moore. It's going to be, it is a challenging group of patients that are going to show up in the near future, is when, as you are decreasing these age group of these patients and you're implanting these transcatheter aortic valves, at the end of the day, it is a bioprosthetic valve, right? It's just a technique that's different. So we know from history that the bioprosthetic valve, the durability is somewhere between 10 and 20 years. So you are going to face these cohort of patients that are going to come back with valve failures in the near future. And what do you do with these valves? Of course, there are valve-in-valves. You can do another TAVR inside a TAVR. It's a possibility, it's available, but you got to realize that as you keep going down the road, if you have more concomitant problems, like if you have coronary artery disease and things like that, and accessing these coronaries through 2 layers of valve scaffolding is going to be challenging. But you know, I'm hoping that, you know, this is going to be addressed by the companies. We are all going to have more. And this is probably just the tip of the iceberg, you know, and it looks so exciting that, you know, all this is going to be addressed in the future, and you know, we'll have better techniques, better gadgets, and better protocols in place, so we don't end up in a situation where we have put a TAVR now and the guy is only 75 years old and, you know, his valves failed. What do you do now, you know? So it is a very important situation, and we got to be cognizant of that. So having said that, although we have dropped the risk from extreme to a high to an intermediate risk, if you look at all the literature and the data, the age has not necessarily gone down. The mean age has stuck to the 80 years of age, because if you remember that data that I showed you, the first slide, that there are 1 in 3 patients were not operated on or not even referred to. So those are the ones we are catching now. And then, you know, those patients are still 80 years of age. So by the time these fail, probably they are really, you know, something's going to, I'm not hoping, but it's going to happen, is that, you know, they're going to end up with something more in life. For a better word. But the 80 years is what, you know, is kind of encouraging for us to keep going down the risk strata and not worry about the future as to what happens with these failed valves.
Right. Just one more comment or piece of advice for, you know, the healthcare providers, especially the primary care providers. As you can see, the criteria for transcatheter aortic valve replacement is very, very strict. So please don't send your patients for a TAVR. Send them for aortic valve replacement, because they have to meet very, very strict criteria.
True.
And I do think there is some data out there comparing surgical aortic valve with TAVR, and I think compared to the initial valves implanted, the durability so far has looked pretty good.
Yes.
So it's fairly comparable. Dr. Vashis, with this TAVR onset, have you seen any change in surgical practice about implanting surgical metallic valves versus bioprosthetic at the time of surgery, anticipating that, you know, somebody's relatively high risk of bleeding or somebody's opposed to taking Coumadin? Are the surgeons more acceptable of the fact that they can do a bioprosthetic valve?
Yeah, I think now that most centers have a heart team approach, that's actually got the surgeons as well as the interventional cardiologists on board with the patient-centric determination. And I think we are seeing more and more surgeons and cardiologists being accepting of that fact, where if someone would require another procedure down the line, that they would consider doing a bioprosthetic valve or a TAVR. I think we should also recognize that, the bioprosthetic valves as well as the surgical techniques have also gotten better over these years, just as TAVR has emerged. So they are kind of going hand in hand overall.
What about the Analyst? So that AI continues to be the main problem with long-term problems with the TAVR. And do you think there are certain improvements in how you visualize? I know there's a lot of focus on the Analyst, and you try to image it as well as possible. But what degree of AI would want you to consider having a patient go for a vascular plug or something to control that? And is there any data that shows that getting an intervention like that is helpful?
There are post-BAVR, post-valvuloplasty. We did have one patient who had about moderate AI with a little bit of cardiomyopathy, but we looked at him clinically and assessed him. So if we ever do a plug, he'll be the guy. But we are watching him clinically. There's not much data, unfortunately, on if there is a benefit on these patients, whether to plug them or not, especially if their AI is mild and less. So if it's mild and less, we are happy, and that's the trend in the rest of the world as well.
So one of the questions that I've always wanted to ask you is that one of the data-free zones in TAVR is really what is the post-procedural anticoagulation or antiplatelet, and there is no right answer.
That's right.
And so I'm wondering, how do you grapple with that, or how do you choose, antiplatelets versus anticoagulation in some? I mean, even though it's a bioprosthetic valve, there are significant differences between a surgical valve replacement and a TAVR. I mean, there are always these crevices which are not there with surgical replacement. There are procedural issues as well with the device size, with periprocedural stroke. So how do you deal with who gets what?
Good question again. So the protocol for us is to give them aspirin for life and give them Plavix for at least a month. So if for some reason they're unable to do that, for example, there's a guy coming up next couple of weeks. He's allergic to aspirin, so we don't know if you should just do Plavix on him. And if you look at the data, there's not enough data to say you have to do dual antiplatelets, and they don't even have a time frame for it. So I guess we again take it by case-to-case situation. And most of these patients are the older cohorts, and they already have atrial fibrillation. They're already on NOACs or Coumadin. So we go gentle on them because there's these octogenarians and higher. So you're better off not being too aggressive and just doing minimum antiplatelets on these because of the kind of population we deal with. But aspirin, of course, if they can take it for life, we'll do that, and Plavix for 30 days.
One of the other comments, just for trainees in the audience, is that with these valves now getting implanted more and more, I think they are a significant challenge to engage coronary arteries coming back. And they can be a nightmare. There are probably going to be different techniques and different catheters. They're not the same as how you engage coronary arteries in native vessels. So I think that's going to be a huge challenge for patients who will live longer and will have restenosis and other interventions that will be required.
True, yeah. For the interventionalists in the room, there is actually there is some literature on how to access these coronaries when you ever end up with a situation. You have to go through these scaffoldings, these little openings in the valve, metal openings. So they say not to go from underneath, and you have to go from the top of the valve. So if it made sense, it's more a technical thing. But it is challenging. And if you're talking about a TAVR in a few years, welcome to interventional cardiology.
Investigating questionable lesions with more advanced techniques when you're getting ready to do a TAVR, and has the fact that a patient has had a TAVR affect how you treat their coronary artery disease clinically?
It's a question for me.
Okay.
Well, I think absolutely. I think if you have an intermediate lesion and patients going for TAVR, I think behooves us to basically be very confident of what that lesion is. I don't think you can just have an angiographic determination of a 50% lesion. I think you may want to do an FFR. And I think your point's well taken that you would want to fix everything that you can. But that's not the panacea necessarily. You could have restenosis, you can have other things. I think as we do more and more TAVRs, I think the interventional training is going to be evolving as well, because earlier when you would see very heavily calcified bifurcational left mains, you would, either say, they'll go for surgical replacement, and they'll get a bypass as well. But now with, valve replacement surgical off the table for certain patients, I think you'll have to become facile in being able to, rotoblader these left mains. And so I think there has to be a different kind of an approach or mindset to these patients. But I absolutely agree with you that whatever coronary disease that needs to be fixed, you have to fix it. And I think you'll also do not want to leave anything which is unanswered or indeterminate. So you would have to have more sophisticated ways, either an FFR or an IVUS or OCT or some mechanism to demonstrate objectively if that is really a lesion that needs to be dealt with.
Yeah, I agree totally. If prior to TAVR, you want to be as aggressive with the lesion, and probably, if you have a situation post-TAVR, you want to be conservative because, it entails complication, trying to access those coronaries. It's just a blanket statement. It doesn't mean that you're going to change, guideline-directed therapy, but, that's the truth of it. Thank you all. Just have a couple of comments, I think closing remarks, right? Yes? Yeah. Thank you.